Chapter 22, Abdominal Emergencies. Talk about some anatomy and physiology of abdominal emergencies and what to look for, kind of what we're looking at. So, the abdomen contains many organs from several different body systems that can cause confusion when determining the cause of abdominal emergencies. These are sometimes hard to diagnose and hard to treat if we don't know what's going on. Thorough patient assessment is key. Specific diagnosis may not be necessary. Treatment is kind of the same for a lot of these conditions, but if we know what's going on, it can make it a lot easier. So the abdomen is the region between the diaphragm and the pelvis. It contains many organs. Provide the following functions: digestive, reproductive, endocrine, and regulatory. So here's coming to some of the organs of the abdomen. We have some solid organs. We've got the spleen over here on the left side, the liver on the right side, the pancreas, they're kind of in the middle, and then the kidneys. Okay? Our hollow organs include the stomach, the gallbladder, the duodenum, the large intestine, back here too, and the small intestine, and then the bladder. So our abdomen is divided into 4 quadrants. There's the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Okay? And there's that. And then you have the umbilicus kind of meeting them all together there. So we've got different organs in the abdomen. We've got the peritoneum, thin membrane lining the abdominal cavity and covering each organ. The parietal peritoneum attached to the abdominal wall, and the visceral peritoneum covers each organ. Okay? Most enclosed with the parietal peritoneum. Few lie in the extraperitoneal space known as outside the peritoneum. Kidneys, the pancreas, part of the aorta lie in the retroperitoneal space behind the peritoneum. The bladder and part of the rectum lie inferior below the peritoneum. Okay? So abdominal pain and discomfort. We get a lot of this, probably 30% of what we go on. So visceral pain originates from the organs within the abdomen. Fewer nerve endings allow for only diffuse sensations of pain. It's frequently described as dull or achy. It's hard for them to pinpoint. Okay? Colic, intermittent pain, may result from distension and or contraction of hollow organs. Persistent or constant pain often originates from solid organs. So parietal pain originates from the parietal peritoneum. Many nerve endings allow for specific, efficient sensations of pain. It's frequently described as very sharp. It's often severe, constant, and located in a specific area. Tearing pain. Most common type of tearing of abdominal pain, it originates in the aorta. Separation of the layers of this large blood vessel caused by an aneurysm. This is very painful and can be deadly. The retroperitoneal location of the aorta causes pain to be referred to the back. Referred pain is perception of pain in skin or muscles at distant locations. The abdomen has many nerves from different parts of the nervous system. These nerve pathways overlap as they return to the spinal cord. Pain sensation is transmitted from one system to another. So we have some of these. Sometimes you get shoulder pain with abdominal pain. That's a certain illness, certain injury. So, infection of the appendix and appendicitis. You'll have nausea and sometimes vomiting. Pain often initially referred to the umbilical region, followed by persistent right lower quadrant. So anytime somebody says right lower quadrant, we're going to start automatically thinking maybe appendicitis. Rupture of appendix is a severe, sudden increase in pain. The contents releasing in the abdomen cause severe peritonitis and can be deadly. Peritonitis is an irritation of the peritoneum, usually caused by foreign material in the peritoneal space. Parietal peritoneum is sensitive, especially to acidic substances. Irritation causes involuntary contraction of the abdominal muscles, and then we're going to have a lot of severe abdominal pain and rigidity. Okay? Cholecystitis or gallstones is inflammation of the gallbladder, often caused by blockage of its outlets by gallstones. Okay? Symptoms often worsen by ingestion of fatty foods. You'll see a lot of these folks will be doing certain diets, certain very restricted diets. They won't eat any fried foods or anything like that because of their diets. So they're trying to limit that stuff. Severe right upper quadrant or epigastric pain. Pain is often referred to the shoulder. This is what I started talking about a second ago. So Cholecystitis is going to have some shoulder pain with it. It's a good identifier. I don't think that's on the test, but you might in National Registry get a question about referred shoulder pain and what illness is related. Pancreatitis is inflammation of the pancreas. It's common in patients with chronic alcohol abuse. So earlier, last chapter, I think we were talking about alcohol abuse and how it can have other effects on you. Well, here you go. Okay, you can have pancreatitis. Signs and symptoms: epigastric pain, often referred to the back and or shoulder. GI bleeding, hemorrhage within the lumen of the GI tract, maybe minor to severe. Blood eventually exits mouth or rectum. So depending on where that GI bleed is, if it's an upper GI bleed, they're normally vomiting out blood. If it's a lower GI bleed, it's normally in their diarrhea. Sometimes painless. You can also have gastric ulcers, which are holes in the GI system from highly acidic gastric juices that can cause severe and pain peritonitis. Dark colored stool, often described as tarry stool, a lot of times will be seen, or frank blood from the rectum is typically a hemorrhoid. Vomiting coffee ground appearing blood is typically an upper GI bleed. Pain can be absent to severe. An abdominal aortic aneurysm, also known as a AAA. It's ballooning or weakening of the interior wall of the aorta. Tears and separates from the outer layer, that would be a dissection. Or the weakened vessels bulge and they continue to grow and they can eventually rupture, right? It can be extremely dangerous. Often they'll feel this sharp tearing sensation. Frequently it radiates to the back. There's normally a palpable abdominal mass. Sometimes it's pulsating. If it's pulsating, that's a pretty bad deal. You could have inequality in pedal pulses. This is a very life-threatening condition. Sudden severe increase in pain may indicate rupture. High aortic pressure causes rapid internal bleeding. Sudden progression of shock and likely exsanguination. They're likely to die in this situation. The best thing to do is keep them in a position where it's clamped off. So if they're talking to you in one position, don't move them from that position. So if they're sitting upright and they're doing okay, but they lay down, they're going to go unconscious and die. So keep them in the position that you think that it's going to keep that clamped off. Hernia is a hole in the muscle layer of the abdominal wall, allowing tissues or parts of organs to protrude up against the skin. These are pretty common, mostly in adult males when they're lifting. Typically has this happen sometimes. Maybe precipitated by heavy lifting, may cause strangulation of tissue or bowel obstruction, can be dangerous, and it may require surgical repair. Sudden onset of abdominal pain, often following exertion. It's going to be a palpable mass or lump on the abdominal wall or crease of the groin. Renal colic, severe flank pain caused by kidney stones traveling down the ureter. Signs and symptoms is normally severe cramping, intermittent pain in the flank or the back, frequently referred to the groin, nausea, and vomiting. These patients are going to be in severe pain, so the worst pain. Some people say this is as bad as having a baby. Cardiac involvement. You can have some abdominal pain from cardiac involvement. Pain from the myocardial infarction may be felt as abdominal discomfort. This is why we do 12 leads on abdominal pain. Epigastric pain, indigestion, or digestive discomfort. Always consider the possibility of a cardiac emergency. If they have an abdominal pain, we need to check for a cardiac emergency. We're going to assessment and care of abdominal pain or discomfort. So there's a lot of potential causes. Our role of EMT is not to diagnose. We're going to focus our efforts on performing a thorough secondary assessment and identifying serious or life-threatening conditions. So we're going to try to figure out what we can determine based on our assessment. We're going to do a good seed size up, make sure there's nothing that sticks out that could be causing this. See if it's medical trauma or both. We're going to try to get a good general impression, get our good ABCs, figure out level of consciousness. Consider application of supplemental oxygen in the hypoxic abdominal pain. See what's going on. So, we're going to go through our OPQRST. And then we're going to ask some specific questions for females. Where are you in your menstrual cycle? It's important for any female with abdominal pain to be asked these questions. Is your period late? Do you have bleeding from the vagina that is not menstrual bleeding? If you are menstruating, is it your normal flow? Have you had pain like this before? If so, when did it happen and what was it like? Is it possible you are pregnant? This is an awkward question you have to ask. You have to ask it. Is it possible you're pregnant? And then are you using birth control, and if so, what type? Then we're going to go into our sample. Signs, symptoms, allergies, medications, past pregnant history, last oral intake, and events leading up to this. Geriatrics are going to have decreased ability to perceive pain, so they're more serious causes of abdominal pain, more likely to be life-threatening, maybe complicated by medications. Why do you think this is? Why are they less likely to perceive that pain? A lot of them are already on medications. A lot of them are already on pain medications. So for them to notice new pain, it's going to be more severe. We're going to do a physical exam of the abdomen. Is it distended? Is it discolored? Are there protrusions? We're going to use our fingertips to palpate around. We're going to palpate the painful area last, starting with the non-painful area, working our way up. Is the abdomen rigid? Are they guarding? Guarding means kind of blocking it away from you. We're going to do vital signs every 5 minutes. We're going to consider these patients critical since we don't know exactly what's going on, and we're going to hit all those things. General abdominal distress. Some will result from digestive system disorders. Others could be cardiac or diabetic or even food poisoning or the flu, right? So we got to check through all those things. We want to make sure that we keep an eye on the airway. If they're vomiting, always work to calm the patient. We want to keep them as calm as possible and not give them anything by mouth, okay? We're trying to avoid that in case they have to go to surgery. To maintain that airway, be prepared to suction, administer oxygen if they're hypoxic, place in a position of comfort, left lateral recumbent to protect the airway. We're going to transport to an appropriate facility. So that is abdominal emergencies.